Good evening and thank you everyone for joining us today. On behalf of NAARI division of Jagsonpal Pharmaceuticals Ltd, I, Amit Saxena, along with my teammates from Medical Services, Dr. Deepika Chawla and Mr. Arvind Singh, and Mr. Mukesh Awasthi, Head Sales and Marketing NAARI division, are delighted to welcome you all to today's academic session with esteemed experts. Today's discussion are brought to you by NAARI division of Jagsonpal Pharmaceuticals Ltd, makers of Uliprist 5 mg tablet of Ulipristal Acetate and Fibristone 25 mg tablets contains Mifepristone. A warm and hearty welcome to esteemed experts and attendees today. Dear attendees, we request you to post your suggestions, questions, clarifications by text in Q&A box. Please note this webinar is streaming live on Facebook and the link will be all shared in the chat bot. To refer this webinar recording in future, please visit our YouTube channel Jagsonpal Medical Insights. To initiate today's sessions, now I request Dr. Deepika Chawla, General Manager, Medical Services, to please invite and introduce our experts today.
Thank you, Mr. Amit. Now we welcome and thank the experts for their time and commitment to women's health. And we are very fortunate to have experts from East India to join us today for this knowledge sharing webinar. Thank you, Dr. Basab Mukherjee, for facilitating this webinar. Dr. Basab Mukherjee is fertility specialist, Ankuran IVF Center from Kolkata, and he is Vice President FOGSI and Bengal Obs and Gynae Society also. He is the organizing secretary for AICOG 2023 at Kolkata. He's held many prestigious office positions in so many gynae forums, contributed over 30 chapters in textbooks. He also holds office of the secretary AICC-RCOG East, India East. Welcome, sir.
Thank you.
We welcome Dr. Meena Samant. Dr. Meena Samant is Senior Consultant in HOD at Kurji Holy Family Hospital at Patna. She is Chairperson FOGSI Clinical Research Committee and President-elect Patna Obs Gynae Society, besides having organized many academic events and Dr. Kamini Rao oration. Dr. Meena Samant is a DNB teacher and has many papers published in reputed journals and chapters in books. Welcome, ma'am. We welcome President Guwahati Obs and Gynae Society, Dr. Nilakshi Phukan, Director, Gynaec Center, Guwahati, and Consultant, Downtown Hospital, Guwahati. Dr. Nilakshi has been actively involved in Indian Menopause Society and AICOG, Guwahati. Her interest also lies in spreading cancer awareness in women of Northeast region, as she also works with SME NGO. Welcome, Dr. Nilakshi. We have with us today Dr. Sangam from AIIMS Patna, who will throw light on the role of SPRMS in management of uterine fibroids. Now we will request Dr. Basab Mukherjee to kindly initiate the program and then introduce our speaker for the session today. Sir.
Thank you, Dr. Deepika. Such a pleasure to be here, such a pleasure to connect. So first of all, I congratulate Jagsonpal on their initiative of spreading out this knowledge of medical management of fibroids. You must all be aware that in both in FOGSI and general practice, I think Preserve the Uterus is a campaign that we all are looking forward to. And the Preserve the Uterus can best be done if you look at two different angles to approach it. One is the fibroid angle and one is the endometriosis angle. So the fibroid angle would generally be looking at medical management for symptomatic fibroids. And that is where the Ulipristal was the kid in the block, or the only person in the block for a fair amount of time till Mifepristone came into the picture. Now Ulipristal is back, and each of them have their place, and that's what we're going to hear from Dr. Sangam. Where does each of them place, or what the evidence that she has done, her research and studies shows us. We also will be hearing from our experts on the clinical practice that they do practice in medical management of fibroids, which are the indications that they prescribe these medicines. Is it perimenopausal? Is it pre-surgery? Is it others? And this is what we would like to hear and learn from their experience and learn from the clinical learnings that they have. The audience will be free to please put your questions in the chat box. This is an educational initiative. It's for every one of us to learn from each other and to just to deliver better medical treatment to our patients. And this is one of the for the medical management of fibroids. So I don't want to, we have 1 solid hour to spend here. So 45 minutes, around 20 minutes would be the talk. Another 20 to 25 minutes would be the discussion. And we would be wrapping up at 8 o'clock. So we really have to be brief and to the point, and have a lot of experience sharing and to have some good carry home points for all of our attendees here. So Dr. Sangam, I would have the pleasure to introduce you. If we have her slide, Dr. Sangam is an associate professor at AIIMS Patna. She has a lot of publications in national and international journals, more than 30 of the same. And among them, she has also published chapters in Dasgupta's Recent Advances 12th edition, presented papers in national conferences from FOGSI 06 to NYCon 19 RCOG 2019 in Kolkata. Is on RCOG 21. She's received the Dr. Nirmala Saxena Award for the best poster on the official theme at the Bihar Obscine Society Conference, delivered talks in states and national conference, trained in advanced obstetrics, ultrasound and Doppler, also advanced fertility management. She is a life member of FOGSI with the teaching experience of 14 years, a national master trainer, and the special interest in a lot of subjects. But here, what we are going to focus on is the medical management of fibroids and the use of SPRMS. Dr. Sangam, it's all yours. We'd love to hear from you and the next 15 to 20 minutes, and then we take a discussion where we will include you there, and we'd also hear from Dr. Meena and Dr. Nilakshi.
Thank you, sir. Thank you so much for giving a kind introduction about me. It's an honor to be introduced by the leading light here.
A very good evening to respected seniors, esteemed experts for today's CME, and all the delegates who have joined for today's CME. I will be speaking on the role of selective progesterone receptor modulators in the management of uterine fibroid. Leiomyomas are the most common gynecological benign tumors, and they are supposed to be a monoclonal pelvic tumors, which affects around 35 to 77% of the reproductive age women. And the incidence increases with the increasing age, and it peaks around at 40 years of age. It present in the 5 to 10% of the infertile patient, and it may be the sole cause for infertility in around 1 to 2.4% of the women. It is one of the most frequent indication for hysterectomy. And as per one study, in India, approximately 15 to 20 million women suffer from fibroids, and this speaks the volume of the disease. So this was the classification based on the anatomical location of the leiomyoma given by FIGO. I will not be going into details. So as per this classification, the myoma has been classified into 8 classes depending on its anatomical location and relation with the endometrium and the parametrium. This was a second classification given by the Endoscopic Society for European Society for Gynecological Endoscopy for the submucous myomas, and it has been classified into three categories depending on the myometrial extension and the angle of myoma surface to the uterine wall. So why this fibroid occurs? Why some women are predisposed to develop myoma? So exact pathophysiology is not known as yet. However, the studies has shown that genetic factors and the epigenetic factor may initiate the changes in the myometrial cells. And then there is a cellular transformation into myofibroblastic phenotype, which results in the leiomyoma growth. And the growth of the leiomyoma is promoted by estrogen, progesterone through release of growth factors, cytokines, and chemokines. So the basic initiator are the genetic factors and the epigenetic factors, and the promoters are estrogen, progesterone, which affect through the release of growth factors, cytokines, and chemokines. So ovarian progesterone acts via progesterone receptor to regulate transcription of the key genes for apoptosis, proliferation, and extracellular matrix formation. Progesterone has dual action. It stimulates growth by upregulating epidermal growth factor and BCL2, and it can inhibit growth by down-regulating insulin-like growth factor 1 expression. Usually, the myomas are asymptomatic, and when symptomatic, it can present with dysmenorrhea, heavy menstrual bleeding, pelvic pressure, chronic pelvic pain, infertility, or sometimes patient may present with the features of iron deficiency anemia. The currently available treatment option for fibroid are expectant management when it is asymptomatic, medical management, or the surgical management. Surgical management includes the minimal invasive technique or the conventional technique. I won't be going into detail of these management. Medical management has expanded in the last few years from the simple analgesic to the hormonal treatment, from combined oral contraceptive pills to the progesterone-only pills, then the denazole, GnRH analogs, and currently the selective progesterone receptor modulators. So conventional drug which has been used for the control of myoma symptoms were oral contraceptive pills. But however, these are associated with certain disadvantages, and sometimes it may increase the size of myoma. Patient might complain of breakthrough bleeding, and it also increases the risk for venous thromboembolism. Progesterone, again being a hormonal treatment, is associated with inconsistent bleeding pattern, sometimes hypoestrogenic side effects, and there can be development of ovarian follicular cyst. LNG-IUS has a high expulsion rate due to distortion of the endometrial cavity, and there can be development of ovarian cyst and acne. GnRH agonist does have a good effect on the symptoms of myoma as well as myoma size. However, it's associated with hypoestrogenic effects like hot flashes, decrease in the bone mineral density. So the long-term use of GnRH agonist is not recommended beyond 6 months. So denazole is out of scene because of its androgenic side effects, and the symptomatic treatment do not reduce the fibroid size, and limited data in the symptomatic uterine fibroid. So now we have the newer options like selective progesterone receptor modulators. The studies has shown the role of progesterone in the growth and development of leiomyoma, and this knowledge has led to the increased interest in the progesterone receptor modulation for the modulation for the treatment of fibroids. So these are the new class of progesterone ligands displaying tissue selective agonist and antagonist or mixed activity on the target cells. So they have an anti-proliferative, anti-fibrotic, and pro-apoptotic effect. So this timeline shows the SPRM development. So first selective progesterone receptor modulators was discovered in 1980, and it was a Mifepristone. It was discovered during the quest for the discovery of anti-glucocorticoids drug. The second was discovered in the 1990 was a esoprisnil, and finally in 2010 it was Ulipristal Acetate. So this pyramid shows the agonistic to antagonistic progestational effect. The arrow demonstrates increasing level of progesterone antagonism of the various modulators, and as we can see, the progesterone are progesterone agonist, and at the lowermost level it's a complete antagonist. So we can see this Ulipristal is the mid of the pyramid, having a both agonist and antagonistic effect on the progesterone receptors. So it basically acts on the HPO axis and reduces the LS surge and hence inhibits ovulation, however, maintaining the estrogen level at the mid-follicular level. So there is a induction of amenorrhea, however, hypoestrogenic effect is prevented. It acts directly on the fibroids, blocks the progesterone receptor, and prevents the cell proliferation, induces apoptosis, and induces fibrosis. It acts directly on the endometrium, and it transforms the endometrium into atrophic endometrium. The first modulator which has been used for in the fibroid was the Mifepristone, and it was approved by FDA on September 28 in 2000. It reacts with the progesterone receptor in the myoma and reduces its size. So varying dose regimen have been suggested for the treatment of fibroid, though consensus is for a dose between 10 to 25 milligram daily. Higher doses have not shown any increase in the beneficial effect. So what the evidence we have for its use in the myoma treatment? This was a study published from All India Institute of Medical Sciences, New Delhi. The author used the low-dose Mifepristone in the medical management of uterine leiomyoma, and they found that Mifepristone in the dose of 10 and 25 milligram caused symptomatic relief with the more than 90% reduction in the menstrual blood. Greater myoma size reduction occurred with 25 milligram dose, and amenorrhea was developed in 90 to 95% patient, which was reversible. So they concluded that it can be a reasonable choice for the management of uterine leiomyoma. This second study was published from Nigeria. Here a total of 30 women were selected to receive 25 milligram Mifepristone daily for the period of 6 months. And they found that after 180 days of treatment, there was 47% reduction in the leiomyoma volume and 53% reduction in the uterine volume. There was a symptomatic improvement also, and hence author concluded 25 milligram Mifepristone produced a reduction in the leiomyoma size, uterine volume, and its symptoms. This was a third study, again published from India. Here the author compared Mifepristone with the Ulipristal acetate for the management of leiomyoma. Here the author categorized patients in two groups depending on the myoma size. The one group had a myoma of less than 3 centimeter size, and the second group having a myoma size of 3 to 5 centimeter. Both the group have been divided into two groups. One group received Mifepristone, and the second group received the Ulipristal acetate. And the author found that 25 milligram dose of Mifepristone is shown to be a good and effective way of treatment in fibroid less than 3 centimeter in size. However, Ulipristal was better in other subgroup with the size 3 to 5 centimeter. However, author concluded that still larger RCTs are needed to study the long-term benefit of these drugs, as they have only 40 patients in the study group. So this was a Cochrane database systemic review published in 2012 on Mifepristone for the uterine fibroid. Here, after a systemic review, the author concluded Mifepristone reduces heavy menstrual bleeding and improved fibroid-specific quality of life. However, it was not found to reduce fibroid volume. So, recommended further well-designed, adequately powered RCTs for before a recommendation can be made on the use of Mifepristone for the treatment of uterine fibroids. The second molecule, which has been marketed as a selective progesterone receptor modulator, was the Ulipristal acetate. It is an orally active synthetic modulator approved by European Union for pre-operative treatment of the uterine fibroid in 2012. And today it's one of the most effective medication for the conservative management of uterine fibroids. It is rapidly absorbed from the GI tract and has a good oral bioavailability. It is highly protein bound, readily converted to its metabolites predominantly via CYP3A4 enzyme. Main route of elimination is through feces, and less than 10% is excreted in urine. So most of the evidence for the use of UPA in the myoma is available from these three trials. The first trial was the Pearl trial, which was conducted in 4 phases, and it was conducted in the European centers. Only Caucasian women were included, and the author has kept a strict BMI cutoff. The second trial was conducted in the USA. It was conducted in 2 phases, and it was named a Venus trial. It included African and American women. However, the author did not keep any BMI cutoff. The third was the Premier trial, which was a real-world experience after these 2 trials. Here, the author used Ulipristal acetate in the pre-operative period for the myoma size reduction. All the trials have demonstrated positive impact of UPA on reduction of fibroid-related symptoms and its size. So, previous trials and studies have shown that 1 tablet of 5 milligrams should be taken orally once daily, starting from the 5th day of menstrual cycle, and can be given continuously for 3 months. However, the retreatment course should be started after second menstruation. Repeated intermittent treatment can be given up to 4 intermittent courses. And this is important that a gap of 2 menstrual cycles should be given before starting a second course. In case if a patient misses a dose, a patient should take a UPA as soon as possible. If dose was missed by more than 12 hours, patient should not take the missed dose and simply resume the usual schedule from the next day. So common indication for UPA in fibroids are Women with less than 40 years of age presenting with symptomatic myoma, deforming the uterine cavity and suffering from infertility. Women who are more than 40 years of age presenting with the symptomatic fibroids, and premenopausal women presenting with the symptomatic fibroid but are desirous of preserving their uterus. So there are few contraindications too. So it should not be used in a patient with a severe liver disease. A negative pregnancy test should be ensured before starting the drug. It should not be used in case of genital bleeding of unknown etiology. Uterine, cervical, ovarian or breast cancer should be excluded. The data is not available for the use in the postmenopausal woman. Severe asthma, insufficient control on the oral glucocorticoids as it had some anti-glucocorticoid activity also. Coagulation disorder and endometrial hyperplasia. So during a post-marketing period, 8 cases of severe liver injury were identified, and out of this 4 required liver transplant. So drug was banned for further review on its overall safety. DCGI banned this drug in November 2020. However, in the Pharmacovigilance Risk Assessment Committee of the EMA concluded that UPA might have contributed to the development of some cases of severe liver injury. However, the status of Ulipristal acetate as a medication responsible for drug-induced liver injury was not fully confirmed. So, the drug was reintroduced in the market with clinical restrictions. So, DCGI has revoked this ban on 13 December 2021 with certain clinical restriction and the safety monitoring. The following measure and it advised following measures to minimize a possible risk for liver injury. That this should not be used in the patient with the underlying liver diseases. Liver function tests to be performed before starting each treatment course and fortnightly thereafter during the treatment. It should not be started if the liver enzymes are raised 2 times the upper limit of normal, and treatment should be stopped if the liver enzyme rises 3 times above the normal limit. The restricted clinical use was recommended by DCGI that drugs should be used in the premenopausal women who are not fit for the surgery, including the uterine artery embolization. It should not be used preoperatively for the control of symptoms. Warning should be included in the educational materials for doctors, package insert, and the label. The drug has been associated with irreversible liver damage, even leading to death. So caution should be used when this drug is prescribed. Liver function test should be done prior to prescribing the drug, and the drug should be stopped when the liver function gets deranged. So real world data from the India. This was a study on the safety and efficacy of 2 repeated cycles of Ulipristal acetate in the management of symptomatic uterine fibroid among the Indian women. It was conducted at All India Institute of Medical Sciences, Patna. This was a longitudinal prospective study. The previous trial included mostly Caucasian women or American or African women who were racially different from the Indian population. And in addition, only few studies evaluated the impact of Ulipristal acetate therapy on vascular indices of fibroid. So we aim to evaluate the safety and efficacy along with the impact on uterine and fibroid vascular indices of 2 repeat 12-week courses of Ulipristal acetate among the Indian women. All premenopausal women aged 18 to 45 years who had at least 1 symptomatic fibroid ranging from 1 to 10 centimeters were included in the study. Symptomatic fibroid was defined as the presence of symptoms like heavy menstrual bleeding or pelvic pressure or pelvic mass. The following were the exclusion criteria. Women having any of this disease were excluded from the study. So 94 women were included in the study who fulfilled the inclusion criteria. All of them received 2 courses of 5 milligram of Ulipristal acetate for 12 weeks, starting from the 5th day of menstrual cycle, with the 2 menstrual cycle break in between. They were scheduled for visits. The first visit, menorrhagia, was assessed using pictorial blood assessment chart score, and fibroid and uterus volume were assessed through ultrasonography, along with their vascular indices using power Doppler. At the second visit was scheduled at the end of first treatment cycle. Third visit at the end of second treatment cycle. Fourth and fifth visit were scheduled at 3 months and 6 months after completion of the second treatment cycle, respectively. At each visit, clinical and radiological assessments were done. Liver function test and an endometrial biopsy were performed before starting the treatment and then at the end of first and second treatment cycle. Uterine and fibroid volume were calculated using the ultrasound device. In case of multiple fibroid, the mean volume of up to 3 fibroid was measured. Menorrhagia were assessed using PVAC chart, and score more than 100 corresponding to 80 ml of blood loss during the first 8 days of cycle was considered as menorrhagia. Uterine vascularization was analyzed using RI and PI with the power Doppler. So primary efficacy endpoint was the time to amenorrhea and the percentage of women who achieved amenorrhea, that was PVAC score less than 2 for the last 35 consecutive days during the first treatment cycle. Second efficacy endpoint was the reduction in uterine and fibroid volume as well as its vascularity at the end of first and second treatment cycle. Safety assessment included any adverse effect reported during each treatment cycle or off treatment duration, abnormality of liver function, serum estrogen level, or endometrial pathology. So finally, 94 women were recruited. However, only 86 women completed the first treatment cycle and only 65 women completed the second treatment cycle as the drug was banned in the November 2020. This table shows the demographic data of the studied population. This is a efficacy endpoint result table, and this shows that 54 women achieved amenorrhea from the day 11 to the end of treatment cycle, and the rate of amenorrhea was 79% at the end of first treatment cycle, and it was 82% in the second treatment cycle. There was a significant reduction in the fibroid volume, and around we noted 32% reduction in the fibroid volume at the end of first treatment cycle, and this reduction continued in the second treatment cycle also. As you can see, there was a reduction in the uterine volume also, which was significant, and this reduction continued in the at the end of second treatment cycle. We noted increase in PI and RI indices, which indicate this reduction in the blood supply of the fibroid. We also noted the uterine artery RI-PI value increase. However, this did not reach the statistical significance. So we can say that this drug affected the fibroid vascularity more compared to the uterine vascularity. There was increase in the hemoglobin value also. This reduction continued in the at the third visit and the fourth visit and the fifth visit too. This is a Kaplan-Meier survival curve, which was used to estimate the time to amenorrhea, and where the endpoint was censored at the day 50. Most of the women achieved amenorrhea in the first 11 days, and the median time to amenorrhea was around 7 days at the end of first treatment cycle. Most of the women resumed menstruation after stopping the drug, and the median time to achieve resume menstruation was 24 days. This is a safety analysis result table, and which shows that there was a slight increase in the estrogen level at the end of second treatment cycle, which remained at the similar level at the end of at the second treatment cycle. There was a slight increase from the baseline to the end of first treatment cycle. This was because the first value was taken in the post-menstrual period. However, the second reading was taken just after stopping the first treatment cycle and the second at the second treatment cycle. So this level remained at the mid-follicular level, which was beneficial for the patient, and it was so the use of UPA was not associated with hypoestrogenic effect. The liver enzymes remained at the similar level at the end of first and second treatment cycle. This table shows the adverse event. Around 32% of the women experiences adverse event in the first treatment cycle, and 34% women experienced adverse event in the second treatment cycle. The most common was nausea, hot flashes, and constipation. Only 3.4% women had endometrial hyperplasia in the first treatment cycle and 6.15% in the second treatment cycle. However, all of them returned benign on histology. So we concluded that UPA mediates its action through the upregulation of P21 and P27 genes, resulting in cell cycle delay, causing extracellular matrix constriction by a stimulation of MMP2 expression. This might be responsible for continued efficacy and reduction in the size of fibroid during and after the treatment cycle. The estrogen level were maintained at the mid-follicular phase, which might be the reason for the absence of climactic symptoms. There was a significant increase in the vascularity indices of the core artery following a repeated cycle of UPA treatment, which suggests a reduction in the fibroid blood supply, and which might be contributory to the fibroid shrinkage. There was no serious adverse event among the studied population. So we concluded that UPA was safe, well tolerated, and effective in reducing fibroid-related menorrhagia and its size. Thank you.
Thank you very much, Dr. Sangam. I think it was a very exhaustive detail of management of fibroids. You took us through the pathophysiology, and then you took us through the studies which you have done, and it's with the wonderful results and the international studies which had been there before the ban, and with the relationship on where we stand with the hepatotoxicity now. I acknowledge the presence of Dr. Ramani Devi here. Dr. Ramani is here. She was one of the part of the national expert group. Thank you, Dr. Ramani, for being here. And we will come to you in a minute. But first, we have Dr. Meena and Dr. Nilakshi here, and we would like to hear from them on what they feel about Dr. Sangam's presentation, about the use of both Ulipristal and Mifepristone in the medical management of fibroids. How do they place them in their own clinical practice? And what messages can they leave for us? I'll start with Dr. Nilakshi, and then I'll come to Dr. Meena. Dr. Nilakshi, it's on you. You've heard Dr. Sangam. You have a personal experience of using these molecules. We want to hear from you on your take and your advice to the audience who is listening out there.
Good evening, everyone. Am I audible, Dr.
Yes.
Basab?
Loud and clear. Loud and clear.
Yeah. So we have been using these two molecules for a pretty long time. But in between, we had a lot of problem with Ulipristal acetate. That is why it has taken a little backseat right now. We have been using mifepristone, mostly 25 milligram mifepristone we are using. We are not using in this part of the country 10 milligrams so widely, because we are happy. We have seen the symptom control is better with 25 milligram mifepristone, especially in those cases like where even in the pre-op cases with mostly for hysteroscopic myoma resection cases, suppose the size is big, then we put the mifepristone for 3 months, then it becomes very comfortable to do the TCRM in this group of patients. This is mostly very widely used, and especially the symptomatic patients. But as Dr. Sangam said in one of her talk regarding the using of these molecules in infertility with your cavity distortion, I had a little reservation regarding in this particular point, because suppose it's a grossly it is affected, the cavity is distorted with a fibroid, I think the surgical management will be better.
Definitely, ma'am. Surgical management would be better but for the cases where the myoma size are bigger. Suppose for the polyp, it's always better to go for the hysteroscopic resection. For the myoma which are less than 3 centimeter size, then also the patient can either take a medical management or can go for hysteroscopic resection because it will be easy. For the larger size myoma, so if you'll give a 1 course or 2 course of Ulipristal before proceeding to the surgical resection, that would help in the EG performance or the completion of the myomectomy at one sitting. That would definitely the distorted cavity definitely needs some. So there is a recommendation from
Is it that if the reduction is less than 25% after one treatment course, it's better to proceed with the surgical management. If it is a significant reduction and still distorting the uterine cavity, proceed with the surgical management. And if the size has reduced and is not distorting this cavity, patient can proceed with the fertility treatment.
So definitely your suggestion is like it should be like if it is distorting, it should be treated by surgery.
Yeah, but saying that, Dr. Nilakshi, I think all of us have experienced that even if it is a submucous fibroid where you should not be giving or you have less chance of success, we have given Mifepristone to see a positive result, either for stopping the bleeding, raising the hemoglobin, or just waiting prior to surgery. Yes, the fibroids have not disappeared, but at the same time, the 2 months or the 3 months that you've given it, you have been able to achieve amenorrhea from a place where there was continuous bleeding, which is something which is remarkable for some period of time till you get the hemoglobin up and then go in. And as Dr. Sangam said, maybe 1 sitting instead of 2 sittings. So those are distorted cavities. Those are not classical cases where you would have given Mifepristone, but sometimes we do give because patients insist. And sometimes you are surprised to see that, yes, it does make a little bit of a difference. Dr. Nilakshi, you, and then we'll come to Dr. Meena. Dr. Meena. Yeah.
See, preoperatively, routinely we do not just, but suppose in the submucous myoma, it's bleeding. During bleeding, you cannot perform hysteroscopic myoma resection. So for that particular case, definitely it has a very good, it has a role and controlling that. And another thing that suppose the myoma is a submucous myoma, it's a type 0 or type 1. Type 0 is okay, you can. But type 1, suppose you go for resection and all, just to reduce the size, this medical management is wonderful.
Dr. Meena, can we just move to you? Can we hear from you a little bit on your takes and thoughts on this, what we have discussed, and then we'll move to Dr. Ramani Devi after that. Dr. Meena, your takes.
Yeah, first, congratulations, Dr. Sangam. You've included, a number of Indian studies in your talk, and that's a very good sign because that's what we are looking for, and that adds to the experience now. So we've come a long time since we did not have those 10, 25 milligram tablets, and we would crush those 200 milligram Mifepristone and make into small packets and all that. So Mifepristone, yes, we're using both 10 and even, because 10 patients are responding very well to 10 milligrams, especially lean and thin. I prefer to give 10 milligrams, and I'm a little wary about the endometrial hyperplasia. Then regarding the Ulipristal acetate, yes, like we always say, when we are giving medical management, any management for that matter, patient safety comes first. And that is why there was a little, stepping back with this molecule. And now safety data have come, and now the drug is again in the market. As far as my own experience goes, none of my patient has come up with jaundice or liver dysfunction, fortunately for them and me. And I would say, of course, the symptomatic, as far as bleeding is concerned, it's remarkable. It's pretty consistent. And also, even the size. And I have had patients where it's become really, the size, more than 50% decrease has been seen in the size of the fibromyoma. You know what happens clinically when the patient comes to us, they visited so many peripheries and all that, and they've come to us with the mindset that they have to take the uterus out. Otherwise, they know that there's a tumor inside and it's going to cause them, I don't know what. So that proper counseling because many they have been maybe misguided or whatever that their thought process is. Any tumor in the uterus to mean something to be scared about. So that part of counseling is so important for these patients to know that it's not malignancy, but at the same time we have to be clear where we have to, be keep our eyes and ears open for malignancy if it's a perimenopausal, growing very rapidly, not responding to them, and so on. So, and of course, LDH measurements has become more and more common these days with large and rapidly growing fibroids. Apart from that, the counseling part, that medical management, even any other conservative management is so useful for these patients, for their symptoms, and also conserving, like Dr. Basab started off, how the conservation of the uterus, that is also one of our themes. So that also goes side by side.
Thank you, Dr. Meena. Just a couple of points. I think I would agree with Dr. Nilakshi about the 25 mg use over the 10 mg use. Personally, that's my preference. But again, unless you use 10 mg and get confidence in it, as Dr. Meena is saying that it works possibly as good, we generally stick to a higher dose, expecting a better effect. But again, going by the body weight, going exactly by how it could be, I think we may need to have more trials of 10 mg versus 25 mg to get more confidence that 10 mg is as good. And only if 10 mg doesn't work for 3 months, then you look at 25. But most of us want to give the best for our patients. We don't want to take chances. So you give 25 anyway to start with. And generally, that's what we do. About the endometrial hyperplasia, Meena, I think there has been enough of studies to study that is a cystic in nature. And that is not something which would be malignant or you need to do a biopsy from. I think a lot of research initially had done a lot of biopsies, but they have been reassured. They name it one particular name, progesterone associated.
Progesterone associated endometrial.
Yeah, that's a name. So Dr. Ramani, with that, we'll move on to you. You've heard from Dr. Nilakshi, Dr. Meena, and Dr. Sangam for his wonderful presentation. You have already led this national expert group, which we've had before, and we want to hear your thoughts and your takes on the discussion we've had so far. Dr. Ramani.
Thank you, Dr. Basab and Dr. Deepika, for having made me as expert opinion in this particular topic.
Invited guest, expert opinion. Yeah. You can name yourself, Dr. Ramani. You're here.
Okay.
We want to hear from you.
Okay. So I was just going through Dr. Sangam's presentation. It was an excellent one. And more than that, as it has been her personal work that has to be given weightage in an Indian setup.
Thank you, ma'am.
Thank you. The two main things, that is Mifepristone and Ulipristal, are the progesterone receptor modulators that are used in fibroid management. But basically, I would say fibroid is a disease that has to be managed surgically. Okay, but endometriosis is a disease which has to be managed only medically. See, there is no point in giving a, if you take it according to the classification, there is zero simple thing, hysteroscopic resection, that is going to help. And and except all the intramural subserous myomas, we do not bother anything. But intramural myomas also, unless they are distorting the cavity, we don't have any problem. But invariably, the patient will present with features of menorrhagia and dysmenorrhea. So this particular drugs, Mifepristone and Yuliprist, my experience in fibroid is much more with Ulipristal rather than with Mifepristone. See, but probably the cost that makes us think about using Mifepristone, that is one reason. And again, the side effects, what we get secondary to this Ulipristal, that is also, we think once again before starting the patient on Ulipristal. But I will tell one case report what personally I met with. I wanted to share with you all. One infertile lady who was having multiple myomas around 18 to 20 week size. She has undergone myomectomy, tried initially with lab, then finally landed with the open myomectomy by a senior consultant. Then ultimately after 1 year, she landed with me for fertility treatment. But this time when I did the ultrasound, she was having myriads of leiomyoma. Not a single place in the myometrium was without multiple myomas. That's what I should say. So she wanted to conceive by all means. So I started her on Ulipristal, 5 milligram 4 courses given. Following each course of the Ulipristol, I done an LFT, which was found to be normal. So at the end of 4 months, fairly what the uterine size was around 12 to 14 weeks have come down to 8 weeks. So I was happy this time. And the endometrial cavity, I did a histoscopy, showed a small 1 or 2 submucous myomas, which I removed histoscopically. Then started her on ART. And then fortunately in the first cycle itself, she conceived. Okay, when I did the section, there was a myoma at the lower uterine segment. And again, when after delivering the baby, I could see few myomas getting out of the cavity. So all those things I removed. And after that, she was very comfortable. She was lactating, not menstruating during that time. Then 1.5 years later, she came back once again with the lactational amenorrhea itself. She has conceived. Okay, so this was a spontaneous conception in midst of so much of myomas. So definitely, I think, so the same thing I have experienced with few of my patients for whom I had scheduled them for ART. So in patients, though DCGI says that premenopausal women, only it can be given, but I feel Ulipristol can be given for young patients who are in need of fertility because it doesn't interfere with the ovarian reserve. Again, when you compare GnRH with Ulipristol, GnRH has got an initial flare effect, okay, where the symptoms may be exaggerated. So that is not there with the Ulipristol. So my experience with Mifepristone is only for few patients because I prefer using Ulipristol. So again, with the coming back of this Ulipristol into the market, I personally feel pre-operatively it can still be used because the first improvement is the bleeding comes down rather than the size of the bleeding, size of the myoma. So once when the patient has got reduced bleeding, her hemoglobin can increase. Maybe then we can take her up for the scheduled surgery, though the DCGA says that it should not be given pre-operatively. But I think practically we see that there is definitely the control of symptoms with the improvement in the hemoglobin, plus the size of the myoma also comes down. And as you say, that histoscopic resection, we can do it in a single sitting rather than in a multiple sitting. And likewise, maybe it will be easy for us to go for a laparoscopic surgery also. Laparoscopic myomectomy is also made easier, and the deficits pockets can also be reduced by using a preoperative thing. So with the periodic measurement of LFT and pre-treatment counseling of the patient, these are the 2 important things we have to consider when we are starting the patient on Ulipristol. Tell them that drug-induced liver injury is very, very rare, maybe 1 in lakh or so. And I think in probably, I don't know whether Indians are lucky or not, as far as many of you have said that we do not come across such major adverse effects. And maybe if the LFT is found to be elevated, maybe it's a high time we stop using this.
Dr. Ramani, I will come back. We'll just come with just a few things before we wind up and before we think. I think Dr. Nilakshi, I think one question which a lot of attendees and viewers would be asking, when Ulipristol, when Mifepristone?
Yes.
So is it just a personal choice? Would you think that what you're using, Dr. Ramani has been using more of Ulipristol. You, I presume, have been using more of Mifepristone. Personally, for me, it's mainly a Mifepristone journey after the Ulipristol stumbling block came. Meena, I'm sure, is the same as possibly us. So is there some guidelines? So this is the company Jagsonpal who's come with both the products. Okay, you have to manage fibroids medically. You've got Ulipristol here, you've got Mifepristone here. Which one to use when? This is a difficult question which I'm going to put to all of you. I'll start with Dr. Nilakshi, then Dr. Meena, and then Dr. Ramani, and then we'll wind up with Dr. Sangam's and Deepika's last thoughts. Yeah.
As you say, it's a tricky question, rather. So, like, definitely when Ulipristol came into the market, we were using and we were quite happy because the reduction in the fibroid was much better with Ulipristol than compared with Mifepristone. But with all those controversies and all those liver disease, and it is withdrawn twice from the market, that is why we are using Mifepristone in a wider ways. I mean, than Ulipristol. Suppose we get a very well-defined green signal, definitely, probably we'll like to go for Ulipristol.
Meena, Dr. Meena.
Well, I think size would matter if the pressure symptoms are more. I think, and the effect on the size is more with the Ulipristal. Probably that is where I would prefer to use Ulipristol rather than. But if the hemorrhage part is more, then I would prefer to go by Mifepristone.
Yeah. So I think now it's very clear that if it's Ulipristol, then we have to do those LFTs, the liver enzymes. That's fairly clear. So just a pre-treatment and the post-treatment, even in the middle of treatment, you can always be very skeptical and keep on doing them. That's fine. But as long as we are safe, I think that's acceptable. I think all of us do. But I think one of the very basic things which we have to leave this message here is all this treatment is for symptomatic fibroids. So many times we see isolated fibroids where women doesn't have any symptoms and they are put on these medicines for almost no purpose. So I think it's very, very clear that all this is a medical treatment of symptomatic fibroids, and that's a very important message we want to leave across. Dr. Sangam, some of your thoughts before we wind up. And this is the last talk we'll take.
I have experience of Uliprist.
Yeah, you've done your study on Ulipristal. That's why you're speaking here. Deepika's smiling from one end to another end.
No.
That's the reason why you're like, oh, Ulipristal is your choice.
Sir, my career span is very short. Like I have been practicing for last 12 years only.
That's okay.
So, I started with the Ulipristal. When I started using this Ulipristal, I had this idea that let us study whether it decreases the size or whether it doesn't increase the size. So that's why in the first I did I observed few patients and then I did this study. And while before this study, I found a positive impact on the reduction of especially the amount of blood flow. That is very important. That gives a sense of relief to the patient that something is normal now inside, because they are more worried about the bleeding, menorrhagia, and because they can't do many ritual things, they have to wear pads and also it's a very cumbersome for that. So once they become this bleeding free period is like a good, good thing for them. So definitely decreases this menstrual flow, induces amenorrhea very quickly, are not associated with the hypoestrogenic symptoms. So I have this experience of Uliprist, and definitely it has a good effect during the study period, and I have started prescribing again once this ban was removed.
Thank you, Dr. Sangam. Thank you very much. Dr. Ramani, you will have the last word, and we will conclude the session with your last word and your advice to the attendees who are attending here, your take on the way they should be using and looking at Ulipristal at this present moment.
So number one will be treat the fibroids only if they are symptomatic with Ulipristol or Mifepristone. And with the return of probably the choice of Mifepristone is for uterine fibroids or smaller size, lesser than 3 to 4 centimeters. And the larger fibroids, which are very, very symptomatic, may respond to Ulipristone. Again, there may be improvement in the hemoglobin level and the general well-being of the patient once when she started on Ulipristone. So before starting the drug, we have to assess the liver function test. Then you have a detailed counseling with the patient, then start the patient on drug. So after the first 3 cycles, then ask them to come back, preferably starting on between the day 2 to day 5 of the cycle. 3 cycles, 3 months you are giving continuously. Ask them to come back, do an LFT, then wait for the next periods to come. Then you can start it. Now the Pearl 3 and Pearl 4 trials have proven that even beyond 8 cycles of Ulipristol, it can be used, because the initial trials, Pearl 1 and Pearl 2 were not further. They were giving only short term. So thing is, maybe it is Ulipristol is helpful as a medical management in a short term, or maybe it can be extended to 8 to 10 cycles, not more than that. Maybe by that time, there will be definite shrinkage of the size of the fibroids to nearly 50% of the original volume. Then they can be planned accordingly, whatever is the need. And especially in infertile patients, I think it is very, very useful, because not only my case presentation, but I have heard there are a lot of literature evidence to show that few of the fibroids, like say 2 or 3 fibroids present in an infertile patient, that she can be handled with Ulipristol rather than undergoing myomectomy, which is an invasive procedure.
Thank you, Dr. Ramani. Thank you very much. I think I'll conclude the session here. Dr. Sangam, Dr. Nilakshi, Dr. Meena, Dr. Ramani, it has been a pleasure to discuss this and to take and listen from you, hear from you, and take it forward. Dr. Deepika, I'm reverting back to you, and thank you for including me in this wonderful discussion and session.
Thank you so very much, Dr. Basab, and all the experts present here. All of you have taken time out and really done wonders for this knowledge sharing episode of ours. Now I have my teammate actually with me, Mr. Hitesh. He would just like to share his views about Yuliprist, Fibristone.
Yeah, good evening, ma'am. Good evening, respected senior doctors. To all respected doctors, I, Hitesh, bring greetings from NAARI Division of Jagsonpal Pharma. Am I audible, ma'am?
Yes, yes.
Yeah, thank you. So we thank you for this opportunity to connect with you all today through this webinar, and are proud to present Yuliprist 5mg tablet for long-term management of fibroids. Doctor, please choose the Yuliprist to save her uterus. Dr. We at Jagsonpal are fully compliant with the latest guidelines and recommendations given by CDSCO and DCGI about the liver safety, and suggest the monitoring of LFT at baseline and during the treatment. Doctor, choose Uliprist for the management of uterine fibroids when surgical procedures and embolization are not appropriate or have not worked, or when patient is not willing for surgery. Doctor, dosage of Uliprist. You can start Uliprist on any day of menses, continue and uninterrupted for 3 months, stop the drug, wait for a withdrawal bleed, wait for next menstrual bleed, and pause till second menstrual bleed. Restart Uliprist on any day of second menstrual bleed, continue the same dosage regimen as required. Doctor, Uliprist safe for long-term intermittent therapy up to 8 treatment courses. Uliprist is readily available at all leading counters near to you prescribe. Our sales team visiting you makes it available at discounted rates for your referred and needy patients requiring Uliprist at a subsidized rate. Looking forward to your support to Uliprist. Doctor, we also present Mifepristone 25mg tablet as a Fibristone 25, tones down fibroids, the first generation SPRM, reduces symptoms, improves outcome, safe and well tolerated. 1 tablet daily for 3 to 6 months. Mifepristone and Fibristone is the safe alternative for surgical management of uterine fibroids. Thank you. Please join us again on 19th December for, Doctor, I request you, please join us again on 19th September for Delhi PG Forum for case discussions on pregnancy with anemia. Thank you.
Thank you all so very much, attendees and all the experts, and do join us again.